We are going to be taking our studies today on diabetes management. And it's my hope, and I know we have all heard about diabetes, the way it has ravaged, innocent lives, and what it has caused to people losing their limbs, and sometimes even diabetes causing people to lose their sight. So, as an overview, diabetes is characterized by chronic hyperglycemia due to the inadequate insulin secretion. And sometimes we say that it is the ineffectiveness of the endogenous insulin, which obviously is insulin resistance. So somebody might ask the question that diabetes, actually, as we know it, is significantly more prevalent in the African American, American Indian, and Hispanic populations. Um, and someone might say sometimes it's probably due to obesity and inactivity. There are so many places where diabetes has actually caused a lot of problems. We're talking about contributory factors too. Sometimes it's the development of cardiovascular disease, hypertension, kidney disease, neuropathy, retinopathy, peripheral vascular disease, and stroke. Sometimes when we talk about stroke, cerebrovascular accident. So there are two types of diabetes that we want to take a look at. Number one is type 1 diabetes, which is an autoimmune dysfunction involving the destruction of beta cells, which produce insulin in the islets of Langerhans of the pancreas. That means I'm talking about your pancreas. Obviously, we also have our immune system cells and antibodies that are present in circulation and may also be triggered by certain genetic tissues or by viral infections. So typically when we talk about type 1 diabetes, yes, these are the reasons why people have it. And these are obviously some of the characteristics behind it. Type 1 diabetes usually occurs at a very younger age, and there are no successful interventions to prevent this disease. That means there's no cure for it. Type 2 diabetes, it's a progressive condition due to increasing inability of cells to respond to insulin. And again, we're talking about insulin resistance and decreased production of insulin by the beta cells. This normally occurs later in somebody's life due to, it could be inactivity, it could be hereditary, it could be anything. So you realize that in type 2 diabetes, people get it, during their lifetime. Whilst in type 1 diabetes, normally people really get it right from an earlier onset of it. There are certain things that we need to do as healthcare providers, especially when we understand that we are dealing with a condition known as diabetes. So for you, the nurse, looking at NCLEX, the key thing you need to remember over here is what are the health promotion and disease preventions when it comes to diabetes? Number one, we are talking about diabetes screening. Determine the risk factors. We're talking about obesity, hypertension, inactivity, hyperlipidemia, cigarette smoking, genetic history. We're also looking at elevated C-reactive protein, which is our own CRP. What type of ethnic group do you belong to? And women who have developed infants weighing more than 9 pounds. Okay. Now, we also need to understand that the American Diabetic Association, which is ADA, recommends screening patients or clients who have a BMI greater than 24. I'm talking about the base metabolic index. 24 and age greater than 45 years old. Or if you have a child who is overweight and has additional risk factors. We also want to go back and look at your urine. I'm talking about we need to test your urine for glucose and ketones during routine examinations. Again, the point over here is, do we have any cause to understand that the patient might be going through this type of situations? So what are the client education that you want to provide to your patient in situations like this? Number one, teach the client that exercise and good nutrition are necessary. Very, very important for prevention or controlling diabetes. You also want to instruct your patient to limit calories and decrease total fat intake to about 30% of their total daily calories. You want to encourage a diet, very low in saturated fats. And a lot of the time we're talking about the 3 L's, okay? Low sodium, low fat, and low cholesterol, okay? Keep also in mind that we actually want to encourage the decrease in low density lipoproteins. I'm talking about the LDLs, the very bad cholesterol. You want to assist your patient with weight loss for secondary prevention of diabetes. And again, the goal over here is to help to reduce the risk of heart disease. Let's go back to diet, okay? So what are most important for you to know here? You want to teach your patient about modification of diet to include omega-3 fatty acids and fiber to lower cholesterol levels. Improve blood glucose for clients who have diabetes. For secondary prevention of diabetes, and also at the end of the day, to reduce the risk of heart disease. In all of this, it is very important that as a nurse, okay, going into taking a closer look at your NCLEX, what are some of the risk factors that we want to take a look at based upon the assessment of the patient? Number one, obesity, physical inactivity, high triglycerides, which obviously if they are greater than 250 milligrams per deciliter, then we got a problem right there. And hypertension may lead to development of insulin resistance. Now, there's one thing that I want to state over here. Please always remember that look at insulin, okay? Insulin is like a key. So what does it do? Insulin opens the cell. Okay, that is what insulin does. So technically, when your pancreas releases the insulin gets into your bloodstream, insulin gets into what? Into the cell, opens the cell, and then the sugar, glucose, enters the cell. Okay, so insulin is a key. That is what it does. So if you are not producing enough insulin, or if you're not producing insulin at all, that means you are not opening the cell. So what happens? You have glucose floating all over your bloodstream. That causes hyperglycemia right there. So look at insulin as a key. Okay. So with that said and done, we also want to go back and look at certain things that are risk factors too. We want to look at pancreatitis. We want to look at Cushing's syndrome. These are all secondary causes of diabetes. And then we also want to look at your eyes, vision, and hearing deficits that may interfere with the understanding of teaching, reading of materials, and preparation of medications. Now, let's look at our older adults, right? So they may not be able to drive to the provider's office because of problems with the eyesight. The older adult is always at risk for altered metabolism of medications due to decreased kidney and liver function. And sometimes even when you look at the eyes, right? Think about it over here. Cataracts, okay? We're talking about the opacity of what? Of the lens. Okay? These are all sometimes the results of diabetes. So what are the clinical manifestations? So I have a patient who has diabetes. And you are the nurse, you're going into the patient's room to do an assessment. So what are the clinical manifestations of it? Number one, when we talk about hyperglycemia, blood glucose level usually greater than 250 milligrams per deciliter. Polyuria, excess urine production and frequency from osmotic what? Diuresis. Polydipsia, that is excessive what? Thirst due to, it may come around because of dehydration. Okay, and as a result of polydipsia, which is excessive thirst, it means that you are losing fluids by way of your skin. Okay, that means loss of skin tegor, skin becomes warm and dry. Sometimes you have dry mucous membranes, weak, and you become weak and malaise, right? And then go back and look at the heart. Then the heart may not be working faster enough. Therefore, you may see very rapid, weak pulse. And obviously, there might be a drop in blood pressure, which is hypotension. So those are the key things you want to remember when it comes to polydipsia. Then let's take a closer look at polyphagia, which is excessive hunger and eating. caused from inability of the cells to receive glucose, right? So you see what's going to happen over here. That's what I said earlier on. Think of think of insulin as a key. So it means that when insulin doesn't open the cell to allow sugar to go in, what happens to the cells? The cells begin to cry. They are saying, we need food, we need, So that time, you realize that the cells begin to act up because they are not getting what? Sugar into their system. Why? Because insulin is not opening up. All right. So that is the way you want to understand it to make it what? Easier for you in that regard. All right. So, especially with polyphagia, then client may display weight loss because then the cells begin to shrink. Okay, ketones accumulate in the blood due to breakdown of fatty acids when insulin is not available, resulting in metabolic what? Acidosis. Then that is where we see DKA coming in, diabetic ketoacidosis. You may see Kussmaul's respiration, increased respiration rate, respiratory rate, and depth in attempt to excrete carbon dioxide and acid due to metabolic what? Acidosis. Some other manifestations that you may see include acetone or fruity breath, order due to accumulation of ketones, right? Sometimes the patient might complain about, headaches, again, nausea, vomiting, abdominal pain. They might have the inability to concentrate because think about it over here. If you are not getting enough sugar into your system, enough glucose into the cell, okay, then what happens? Then obviously cells are not getting what they are required, and therefore you may see the loss of certain functions. So that is where concentration comes in, okay? Decreased loss of consciousness. And sometimes it may result in seizures and finally sometimes even to coma. So with all this said and done, you want us to go straight and look at the labs, okay? Because for the purposes of NCLEX, you need to know labs. So what are the labs? Those things that are needed, not the ones you don't need. So diagnostic criteria for diabetes. Number one, includes two findings on separate days of one of the following. Number one, manifestations of diabetes plus casual blood glucose concentration, which is greater than what? 200 milligrams per deciliter, okay? Then you also want to look at the fasting blood glucose. That is greater than 126 milligrams per deciliter. Then we also want to look at a 2-hour glucose, okay, when it's greater than 200 milligrams per deciliter, especially with an oral glucose tolerance test. So I'm talking about OGTT, all right? So those are the things you look for. Then I'm also going to be looking at fasting blood glucose. What are the nursing actions? Number one, so you always want to postpone administration of anti-diabetic medications until after the level is drawn. Your client education instruct the patient to fast no food or drink other than water for the first 8 hours prior to the blood test. So that is for fasting blood glucose. So what about oral glucose tolerance test, which is the OGTT? Number one, a fasting blood glucose level is drawn at the start of the test. The client is then instructed to consume a specific amount of glucose, okay, high levels of glucose. Then the blood glucose levels are obtained. We obtain them every 30 minutes for 2 hours. Now, the client must be assessed for hypoglycemia throughout this procedure. Now, you always want to educate the patient, instruct your patient to consume a balanced diet for 3 days prior to the test. Then instruct the client to fast for 10 to 12 hours prior to the test. Okay, so that is what we do for the OGTT. At the end of the day, what are we talking about over here? Realize that if your patient has a problem with the release of insulin, so it means that if you are giving them very high levels of sugar, the expectation is that if the if the pancreas is normal and is releasing enough glucose, insulin, then obviously, whilst I'm taking the sugar, then the insulin would go in and help to bring the sugar levels down, right? Yes. But for somebody who has a problem with production of insulin, then especially for the OGTT, realize that the more sugar we're giving to the patient, then you don't have enough insulin to bring them down. Therefore, as the hours, as the minutes and hours keep going up and up, then you would expect that your sugar levels will be going up. So that is where the OGTT comes in. Then the next one we want to look at the glycolated hemoglobin, which is hemoglobin A1C. We all heard about A1C, A1C. So at the end of the day, what is it all about? The expected reference range for hemoglobin A1C is 4% to 6%. But we also have an acceptable target, okay? Especially for clients who have diabetes, maybe 6.5% to 8%. Now, their target goal is less than 7%. But ideally, the reference point is 4% to 6%. And now, what is hemoglobin A1C? It is the best indicator of the average blood glucose level for the past 120 days. It assists in evaluating treatment, okay, effectiveness and compliance. So, and again, when we are looking at the average blood glucose for the past 120 days, we're looking at the red blood cells. Okay, so we are looking at the ability for the red blood cells to carry that amount of glucose for the past 120 days. That is an indication you see over there. So what is your client education? So what are you going to do? What are you going to tell your patient? And you are the nurse. Always you want to instruct the patient that a test evaluates treatment effectiveness and compliance. Okay? It is recommended quarterly or twice yearly depending on the glycemic levels. That is for the patient. And then we also want to go and take a closer look at urine ketones. Okay, high ketones in the urine associated with hyperglycemia, especially if it exceeds 300 milligrams per deciliter. And when you see that level, then it means it's a medical emergency. Okay? All right. So those are some of the key things that we want to keep at the back of our minds. Now, somebody might ask the question then, I have a patient with diabetes. So what are the medications? What do we know? What do we need to know about meds? So let's go straight out. Number one, insulin regimens are established always for patients who have type 1 diabetes. And these are, I'm going to spell them out step by step. Okay? Number one, more than one type of insulin. So that means there's no one single insulin that we have. We have more than one. Technically, we have 4 types, okay? So we have rapid insulin. That means rapid acting insulin. We have short acting insulin. We have intermediate acting insulin and the long acting insulin. So these are the 4 types that we have. Now, given one or more times a day based on the patient's blood glucose results. So that is basically how it's distributed. Okay. We also want to remember that insulin may be required by some patients who have type 2 diabetes or women who have gestational diabetes, especially if their glycemic control is not obtained with diet, exercise, and oral hypoglycemic agents. Then we may require that you get exogenous insulin. We also give insulin pens. These are pre-filled cartridges of 150 to 300 units of insulin in a programmable device with disposable needles, especially with the long-acting insulins. Okay, so those are the types. Insulin pens, like I said, they are used if one or insulin is given at a time, and it's very convenient for travels because what it does is once you give it, it spells out for the entire 24 hours. Okay, that is what it is. We also have the oral hypoglycemics. These are used by clients who have type 2 diabetes, along with diet and exercise to regulate their blood glucose. Now, it is very important that you know these oral hypoglycemic agents. You need to know them. Okay? Seriously, but we'll talk about that as we go. If it's okay for now, I would want to talk specifically one by one on the types of insulin. Let's take them one by one. So let's go straight to the rapid acting insulins. Who are they? Somebody might ask the question, what are they? Example, we have Lispro insulin, which is Humalog. We also have Aspart insulin, which is Novolog. And we have Glulisine insulin, which is Apidra. Now, for the rapid acting insulin, administer before meals to control postprandial rise in blood glucose. Their onset is rapid, 10 to 30 minutes, depending on which insulin is administered. Now, you also kind of would want to administer in conjunction with intermediate or long-acting insulin to provide glycemic control between meals and at night. So that is the rapid-acting insulin. Then we have number 2, the short-acting insulin. I'm talking about regular insulin, which is Humulin R or Novolin R. Please administer 30 to 60 minutes before meals, again to control postprandial hyperglycemia. They are available in 2 concentrations, that is 500 units and 100 units. Okay. And also one thing about the regular insulin is that it's the only insulin we can give IV. Okay? Each and every one of them you give sub-Q. But regular insulin, in some cases, especially in hyperkalemia, it can be given IV in conjunction with dextrose. All right, so let's go straight to the third one, which is intermediate acting insulin. I'm talking about MPH. We have MPH insulin, which is Humulin N. Then we also have determere insulin, which is Levemir. Now, they are administered for glycemic control between meals and at night. Yes, that is what it is. I want to make sure I got it right for you guys. Not administered before meals, okay, to control postprandial rise in blood glucose. One key thing about the MPH, especially with the intermediate acting insulins, they contain protamine, which is a protein which causes a delay in insulin absorption, okay, or the onset and extension or duration of action of the insulin. Please administer MPH insulin sub-Q only and as the only insulin to mix with short-acting insulin. So it is a property of it. Administer the determere insulin sub-Q only and is never mixed with other insulin. Okay? So you also want to keep your eye on that. Then let's go to the long-acting insulin. An example is glargine insulin, which is Lantus. It is administered once a day, anytime during the day, but always at the same time each day. Glargine insulin forms microprecipitates that dissolve slowly over 24 hours and maintains a steady blood sugar level with no peaks or troughs. Isn't that so beautiful? All right, so always administer glargine insulin subcutaneously only, and it's never administered IV. Okay, so those are the key things you would want to remember, especially when you have these insulins. A few things you want to add to education. Always provide information regarding self-administration of insulin. You always want to tell your patient to rotate insulin sites. The goal over here is to prevent lipodystrophy, okay, within one anatomical site. It will be best to prevent day-to-day changes in absorption site. And next is always please educate your patient to inject at 90 degrees angle, okay, especially if the patient is, it's not a thin person. But if they are thin, then you want to go at 45 degrees. Please, aspiration for blood is not necessary when it comes to administration of insulin. You want to advise your patient to eat at regular intervals. Again, they can avoid alcohol intake. They need to adjust insulin, especially to exercise and diet to avoid hypoglycemia. Okay? All right. The next thing I want us to talk about is, let's go to the complications, right? So the complications over here, I'm talking about hypoglycemia and hyperglycemia. So a closer look at hypo. What are the manifestations and what are the management? Number one, teach the client measures to take in response to hypoglycemia. That is when you are the nurse, you see mild shakiness, mental confusion. Sometimes you see sweating, patient has palpitations, headache, lack of coordination. Sometimes they'll tell you, I can't see, right? Blurred vision. It could end up in seizures and also in coma. So hypoglycemia preventative measures are to avoid excess insulin, okay, exercise, and alcohol consumption, especially on an empty stomach. Okay, a decrease in food intake or delay in food absorption can also cause hypoglycemia. So let us check blood glucose levels. Yeah, let's check it. And again, ideally, we know that the normal is 70 milligrams per deciliter to 110 milligrams per deciliter. We are taking a closer look at that. Okay, so if your patient has, what do we call it, has hypoglycemia, there are a few guidelines we want to follow. Okay, always instruct your patient who has hypoglycemia, anything less than 70, to take 15 to 20 grams of a readily absorbable carbohydrate. I'm talking about simple sugars, okay? We're talking about fruit juice, regular soft drink, 3 to 4 glucose tablets, 8 to 10 hard candies, or maybe even 1 teaspoon of honey. And then once you do this, you can go back and recheck their blood glucose in 15 minutes. Repeat the administration of carbohydrates, if not within the normal limits. And then you go back again and you check blood glucose in another 15 minutes. Now, if blood glucose is within normal limits, have a snack containing a carbohydrate and protein for the patient. Okay? So those are the key things you want to remember at this point. Now, if your patient is unconscious or if they are unable to swallow, so then that is when we administer glucagon, okay? Subcutaneous or IM. Repeat in 10 minutes if still unconscious. Then you go ahead and you notify the provider, okay? So those are the few things you want to keep your mind on at this point. And then the final one is especially for the hypoglycemia. We know that especially in acute care, the nurse should administer 50% dextrose, okay, if IV access is available, okay? And it's our hope that consciousness should occur within 20 minutes. So 50% dextrose is highly concentrated sugar, okay? All right, let's go to the second one. And this has to do with conditions of hyperglycemia. What are the manifestations and what are the management practices? Number one, teach the client manifestations. These are patients who become very hot, dry skin, and the fruity acetonic breath. Okay, so those are the key things you see over there. You always want to encourage oral fluid intake of sugar-free fluids to prevent dehydration. You want to administer insulin as prescribed. Restrict exercise when blood glucose levels are greater than 250 milligrams per deciliter. You want to go back and also check their urine levels and content, especially for ketones. And at the end of the day, you also want to go back and report whatever you find to the provider, especially with progress related to the manifestations. And we can also go ahead and also give the oral hypoglycemics, which I'm going to be talking about in a few minutes. All right. So let's go now to the oral hypoglycemics. Okay. So these are medications that are given especially to type 2 diabetic patients. So the first thing we want to keep our mind to is we have what we term as the second generation sulfonylureas. These are medications that go with the 3G. When I say the 3G, I'm talking about number one, glipizide, which is glucotrol, glimepiride, which is amylyl, glyburide, which is dibeta, glinase, and prestol. So we call them the 3Gs of the second generation sulfonylureas. Now, mostly with the sulfonylureas, what is their target organ? They target the pancreas. Okay, stimulate the pancreas to produce what? Insulin. Now, they also have a side effect. The side effect over there is hypoglycemia. So what do we do, especially with the second generation sulfonylureas? You always want to give it before meal, sometimes 30 minutes before meal. Okay, so you want to keep your mind on that. Then we also want to go to, and remember I said something. I said the major side effect over there is nursing concentration. It's monitor them for hypoglycemia. Then we want to go to the second one. These are the meglitinides. Okay. Now, these are also medications. For example, we have what? Prandin, which is a repaglinide, and we have neglitinide, which is Stalix. Okay, these are also hypoglycemics that also work on the pancreas. They also have a monitor side effect of hypoglycemia. And in the same way, with this group of medications also, we give 30 minutes before meals. However, if you miss a meal, you miss a dose. You miss a dose, you miss a meal. You don't take it, vice versa. Okay? All right. Then we go to the third. So the third one is what we term as the biguanides. Okay? And the only medication over there is metformin or glucophage. Now the biguanides, please, these are the oral antidiabetics that act on the liver. On the liver. Again, remember that your liver is also very instrumental in storing and releasing glucose. So again, when I'm giving you a biguanide or a metformin, whatever you see, obviously their goal is to help to reduce the release of the production of these sugar components, glycogen, everything from the liver. But they have a side effect. Their side effect has to do with GI. So we're talking about anything related to nausea, vomiting, abdominal pain, flatulence, stuff like that. Okay? And again, keep in mind over there, what do we do, especially with these medications, because they have a side effect of GI, you always take with meals, take with food. All right? So those are the key things to keep in mind. For these foods, for these medications, never crash or chew the medication. Okay? Never crash or chew the medication. So that is something to keep at the back of your mind. Then we also have the next group. So far I've given you three. So I gave you the sulfonylureas, I've given you the meglitinides, I've given you the biguanides. So now I'm going to give you the fourth one. So which are the alpha glucosidase inhibitors. Alpha glucosidase inhibitors. And again, one of the major drugs you see over there is acarbose. The name is what? Precose. Now these are oral diabetics. Where do they act? Actually, they act on the small intestines. Why? Because the small intestines, the goal over there is to cut off, okay, the uptake of carbohydrates or sugar or calories, whatever, from the small intestines into the bloodstream. So that is where these medications, they act. so that you don't have too much of sugar going into what? Into your system. But because it works on the small intestines, which is part of the GI system, therefore these medications, please, they also have a side effect of GI. Abdominal pain, think about it, flatulence, nausea, vomiting, everything you can think about, cramps, excessive gas, name it. So what do we say over here? For these medications, also take with what? With food. Take with food. Then we also have our next one. We're talking about the TZDs. Thiazolidinodines. Again, look, you see the way I'm pronouncing it, right? They're so fun. They're so interesting. In simple terms, I call them the TZDs, as simple as that. All right. And one of our favorite drugs over there is Actos. Okay. These are medications, actually, they end with the ZONE, the zones. But Actos is one of them. Now, what do we learn from here? Now, always keep in mind that these are medications that are very, 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 very important. But unfortunately, they also have a problem over here. These are the medications that are very good, especially against insulin resistance. Against insulin resistance. But they have a major side effect, and it's cardiac. So whenever you're giving these meds to your patient, monitor them for heart failure. Monitor them for fluid retention. So monitor them for weight gain. That's what we are talking about over here. Okay? Very, very what? Important. All right. So those are the key things we want to kind of keep our minds on that. So in all things, when it comes to diabetes, right, we need our patient-centered care. What do we do as nurses? That is what we need to do. Number one, monitor glucose levels and factors affecting their levels. Check intake and output and weight. Check skin integrity. You want to monitor their feet. Okay, look at their sensory alterations, any numbness or tingling, problems with the eyesight, visual alterations, dietary practices. Okay, we're looking at what are their exercise patterns, all the way down to the client's self-medication administration proficiency. Okay, do they have what it takes to do what they have to do for themselves? I'm talking about self-management of the disease. Okay, and that is where a lot of patients have found what? Lacking. You want to teach your patient, especially to provide information regarding self-administration of insulin, rotate injection sites. We talked about that not long too ago. And also make sure that your goal over here is you do foot care. Now, with the foot care, inspect feet daily. Okay. Use mild foot powder. Do not use commercial remedies. Okay. You need to consult a podiatrist. And always avoid open toe or open heel shoes. Wear clean absorbent socks. Do not use hot water bottles. Avoid prolonged sitting, standing, and crossing of legs. And teach your patient to follow, guidelines and recommendations, especially from their podiatrist. That we believe if it's done, it would help the patient very well. Now, a few things to teach your patients, especially when they are sick. Number one, monitor blood glucose every 3 to 4 hours. Number two, continue to take insulin or oral hypoglycemic agents. Encourage your patient to consume 4 ounces of free sugar, non-caffeinated liquid every 30 minutes to prevent dehydration. Tell them to rest. And we want to check their urine for ketones. And at what point do we call the provider? I'm talking about a physician. We're talking about our APPs, advanced practice providers. And especially when blood glucose is greater than 240 milligrams per deciliter. Okay? When they have a fever that is greater than 38.6 degrees Celsius, which is 101.5 degrees Fahrenheit. When patient feels disoriented or confused, when they are experiencing rapid breathing, or sometimes when vomiting occurs, unable to tolerate liquids, or when their illness lasts longer than 2 days. And we always want to say that the care of these patients are very, very what? Collaborative. Very, very collaborative. So that is what we do over there. And a few things that I believe I can share. Always monitor your patient for diabetic retinopathy, impaired vision, and blindness. What is the education you want to provide over there? Encourage yearly eye exam to ensure the health of the eye and to protect vision. You always want to encourage management of blood glucose levels. Then we also want to take a closer look at diabetic neuropathy, right? Obviously, what does that mean? I mean, this is a condition that comes as a result of damage to sensory nerve fibers resulting from pain, resulting in numbness and what? And pain. Especially with diabetic neuropathy, please, we know it's very, very progressive and may affect every aspect of the body, and sometimes when we are not very careful, it can lead to amputations too. So what are your nursing actions? Monitor blood glucose levels, provide food care, encourage annual exam by the podiatrist, and encourage regular follow-up with your provider. Okay? So that is what you do. And unfortunately, you know, diabetes affects everything. So now, what about diabetes affecting the kidneys? Then you have what we term as what? Diabetic what? Nephropathy, right? So this is when there's a damage to the kidneys from prolonged elevated blood glucose levels and dehydration. That means when people have this condition and they were not monitored, okay? So at the end of the day, they end up with destruction of the nephrons, okay? Gone. So what are your nursing actions for this one? Monitor hydration and kidney function, intake and output, specifically serum or creatinine. Report an hourly output of less than 30 mils per hour. Monitor their blood pressure. Okay? Monitor their blood pressure. And you are the nurse. So what are you going to do? You're going to do some client education, don't you? Yes. So always you want to encourage them to have a yearly urine analysis. They need BUN, they need serum creatinine. And please, for the purposes of NCLEX, you need to know what are the normal values for BUN and what are the normal values for creatinine. And next is encourage the patient to avoid sodas, alcohol, toxic levels of Tylenol or any NSAIDs they may be taking. And you want to teach them, encourage them to at least avoid sodas. We all talked about that, and any forms of alcohol, whatever it is. Teach your client to consume 2 to 3 liters per day. Ideally, we know that for every human being, you need between 2 to 4 liters of fluid every day. But for these patients, at least between 2 to 3 liters per day is good enough. Okay? And finally, you want to teach the patient to report any decrease in output to the provider. When we suspect decrease in output, then we know we got a problem with the kidneys, and which may not be a good thing. So we want to keep an eye on that. So this brings us to the end of our presentation on diabetes management, and I hope that helps you. Thank you.